My name is Michael Betel, and I'm the president and founder of the Fatty Liver Alliance. Today, I want to welcome three incredible guests: Dr. Mohit Kehar, pediatric gastroenterologist and hepatologist lead at the Pediatric Fatty Liver Clinic at CHIO, and an assistant professor at the University of Ottawa in Canada. He has a research and clinical interest in pediatric NAFLD and hepatology. We have with us Inez Martincevic, who is a clinical dietitian working in pediatric gastroenterology, hepatology, and nutrition at the Hospital for Sick Children in Toronto, Canada. And we have Amrita Mundh, who's a nurse practitioner at the Hospital for Sick Children in Toronto, Canada, and specializes in NAFLD and NASH in the pediatric population. We regularly hear about NAFLD and NASH in the adult population and the associated risk factors. Today, we're going to learn a lot about the pediatric world of NAFLD and NASH, including a very current update and data about nutrition in that population. Before we move into the presentations, could each of you comment for a moment about why it's so important to focus our attention on children?
Yeah, thanks, Michael, for this opportunity and this invitation to help us advance awareness around pediatric NAFLD. So as you know, pediatric non-alcoholic fatty liver disease is now the most common cause of chronic liver disease in children. And it has been shown that NAFLD is associated with substantial healthcare costs, socioeconomic losses, and also reduced quality of life, most notably in adult patients with advanced cirrhosis. But it's also been noted in children as well. And early detection and intervention at pediatric age could help reduce the burden of the disease and associated healthcare costs and also economic losses. So I hope after today's talk, we'll be able to appreciate this hidden liver crisis.
Thank you.
And so I can comment next. So
Sure.
Children are our future, and I think the pediatric setting is the excellent opportunity to really intervene. We know obesity is definitely a huge risk factor for NAFLD NASH. And so the nature of NAFLD is that it is a progressive disease. And so if we intervene in the pediatric setting, we can help minimize progression of liver disease in this setting and then in the adult world. So you're going to hear a lot about that today. And so I'm very happy to be here today. And thank you so much, Mike, for having me.
Thank you. Inez, anything?
Likewise, Michael, thanks so much for the opportunity. I am even more spoiled by having such an esteemed panel today to discuss a brighter and better future. I think that's the way that I'd like to summarize, a pediatric healthcare. Really, truly echoing my colleagues, they are our future. It's a problem, and we want people to understand it and know that they can intervene. So we hope that the information we'll share today is both insightful, but also can potentially make change for the future. Thanks.
That's excellent setup. Okay, I'm going to pass it over to Mohit to start.
Can you see my screen now?
Yep.
Perfect.
Do you want to make it full screen, Mohit?
Oh, yes, just right.
Okay. There we go.
Good now? Perfect. So thanks again, Michael, for this invitation. So my goal today is to discuss briefly on the epidemiology of pediatric liver disease and how it has evolved over time. I'll also provide some data around the natural history of pediatric NAFLD and some data from Canada. And then hopefully by the end, we'll be able to appreciate that why pediatric NAFLD is like a hidden liver crisis coming our way. So as we know that briefly about the history of NAFLD, it started way back in 1980s with the event of NAFLD as a terminology that was started by Ludwig et al. And then over the past 2 decades or so, there have been rapid evolution in this field from diagnosis to pathogenesis. And in the last 5 to 6 years, there has been rapid evolution on the field in the world of therapeutics. If you just Google, and PubMed NAFLD, there are over 23,000 PubMed articles, and around 2,500 also are around in the pediatric NAFLD world. So how these typically these presents to us, it's a young teenager who is asymptomatic. Some of them might have a bit of fatigue with underlying obesity, and on investigations was found to have mildly increased ALT. Ultrasound was done by physician showing some ecogenic liver, some derangement of lipid profile, not always there, with normal metabolic panel, rest of them. So as we know that pediatric or NAFLD is a spectrum of condition which incorporate a benign steatosis, which certain patients will progress to NASH, which is non-alcoholic steatohepatitis, where there is fibrosis associated with inflammation, and the end stage is cirrhosis. And to basically ascertain which stage you are in, we need a liver biopsy, unfortunately, because there is no dedicated, validated, non-invasive tests that have been validated so far in pediatric world. And over the past 2-3 years, there have been a lot of discussion about MAFLD, which is metabolic associated fatty liver disease, whether we should change the term of MAFLD. So I just wanted to share this 2 slides because it would not be good if I don't touch on this active topic right now. So that there has been a lot of discussion to change this word NAFLD to MAFLD from last 10 years or so, with rapid uh, lot of hepatologists talking about this over the past 2-3 years, that because non-alcoholic fatty liver disease is sort of a negative diagnosis, and alcoholism fortunately is not a big deal in pediatric world so far. But the problem is that NAFLD or MAFLD, whatever you say, it's, the clinicians and the researchers, we all see this diagnosis from a different lens. For some, it is microbiome. For some, it is associated with metabolism. For some, it is a genetic disease. For some, it is just diet. And, eventually, currently, at least, we are in MAFLD. We don't know which term to use. But whatever the pediatric MAFLD criteria have been published, and this was a publication that was done last year in Lancet, where people say that if you have evidence of hepatic steatosis by imaging, by blood markers, if they are eventually available, or histology, and if you have a risk factor of excessive adiposity, that means obese, or if you have type 2 diabetes, then you can label these patients as metabolic associated fatty liver disease. Or if the patient is healthy weight, then you would need to have 2 or more metabolic risk factors, either whether it is a deranged lipid profile, hypertension, or triglyceride to HDL ratios abnormalities. But it is a sort of a tangled path in pediatrics, because especially in our younger children, we see a lot of other diagnoses which can present with steatosis. So not all steatosis for pediatric hepatologists is MAFLD for now. So that this is what I said previously, that it's a spectrum of condition. It moves from one direction to other, but it's not always longitudinal. Sometimes you could see isolated steatosis, especially in adult population, directly moving to cirrhosis, even without event of NASH. So when initially NAFLD was discovered, people used to think it's a two-hit theory, that initially you have liver fat excessive, which drives inflammation, oxidative stress, but that it was found that it's probably too simple to recapitulate the complexity of NAFLD, and there's much more to it. There is a lot of role of microbiome, insulin resistance, your genetics, your epigenetics, and how environment plays a definite role in evolution of this condition. For me, I think that understanding genetics is a key point in diagnosis and even treatment of NAFLD, because I think it's a key aspect why we see so much heterogeneity in our clinics and even in the therapeutic world as well. So these are the 5 common genetic variants which have been published extensively. Some data in pediatrics, not a lot, but mostly in adult literature, with PNP, LA3, and TMCSF2, the main genetic risk factors for advanced liver disease in patients with NAFLD associated with high risk of cirrhosis as well. So coming to a bit of epidemiology, we know that this is now a global epidemic, and no part of the world is basically spared from this condition. Unfortunately, there is not a hardcore epidemiology for data from Canada, but in US, around 25% of adult population is affected with NAFLD. And if you say around 25% of patients with of US adult population has NAFLD, a high association with type 2 diabetes or obesity. Around 5 to 6% of these patients are going to evolve to NASH, with around quarter of them will have advanced fibrosis that is called more than F2. And that what has that evolved into that over the past years or so, the listing for liver transplantation in the adult world has dramatically changed. So if you see these graphs, so this is the non-hepatocellular carcinoma listing in US. This is the data published last year. You can see currently with the event of medication for hepatitis C, the Hep C proportion has dramatically reduced, and the alcoholism and NAFLD is increasing. And if you can see in proportion to 2002, there has been a rapid increase of NAFLD listing in adults versus an alcoholic liver disease has remained sort of stable. And the similar trends are seeing in hepatocellular carcinoma listing in adults as well, which with NAFLD being one of the most common cause of liver transplantation now in younger adults now. What about Canada? So in Canada, we don't have a large amount of data. So this was a publication that was published from Jen Fleming from Queens last year using ICS data. And it shows that by 2040, virtually all cirrhosis in adults will be either secondary to alcoholism or NAFLD. So it's really a concerning trend. In pediatric, we don't have a ton of data, but the epidemiological data is going to be varied upon whether you take histology, you diagnose these patients by imaging or using biomarkers like ALT. And we say around 9 to 10% of world population is affected by NAFLD. But if you are obese, the trend can increase from 30 to 70% depending on the data you chose. And as well, like we saw in adults, the liver disease epidemiology in children has also evolved over the past 2 decades or so. So this is data from enhanced database from United States published last year, which have shown that the prevalence of NAFLD has increased up to 40% in the last years. And there have been increment from 8% to 11.8% in the last 5 years. So, and most of these patients were obese, have associated metabolic dysfunctions, and were male. And this is a trend that has been shown in this paper that was published last year, that it's doesn't matter where you live, whether you live in high socioeconomic status countries versus low versus mid, the prevalence of NAFLD has increased all over the world. So the theme was basically imminent is here with us. In Canada, from a pediatric NAFLD's perspective, there is not a lot of epidemiological data, but we know that pediatric obesity is on rise. So this is a paper that was published by the Primary Healthcare Sentinel Network, showed around 10% of pediatric population in Canada are obese. And these obese children tend to be obese adults. So there has been paper from, especially from Sweden group, because they have a great deal of administrative healthcare database, that the increase of 16%, there has been increase of 16% risk of cirrhosis in adults if you increase 1 unit gain in BMI between the age of 7 to 13 years. So these children who are obese are going to eventually translate into cirrhotic NAFLD later on in life. We have also shown last year that earlier this year that pediatric NAFLD pediatric cirrhosis have been increasing in Ontario over the last 2 decades or so. This is a paper we published in the American Journal of Gastro earlier this year, showing that there have been around 4% increment in the pediatric cirrhosis diagnosis. Most of these children were either infants or teenagers. We were not able to ascertain how much percentage of these teenagers were secondary to NAFLD, but I think there is a good proportion of these patients which are missed. We also showed sometime last year that there has been significant awareness loss in lack of awareness in the primary care healthcare in the world of pediatric NAFLD. This was a survey data which we did in Eastern Ontario, suggesting that only one primary healthcare provider was aware of the guidelines, and 50% of that indicated that they were not aware at all about pediatric NAFLD survey.